Right, welcome to Pharmaco What. It's meant to be a practical approach to pharmacology. So basically we're going to go through some fairly heavy pharmacology, but I've tried to kind of distill it down to the things that I think are actually relevant to day-to-day use of drugs or giving medication to animals. So what we'll cover is some basic pharmacological principles in this talk, and then I'll go on and cover sedatives, induction agents, etc. in separate talks, as well as one just for analgesics. And I figure that pharmacology is going to be a lot more fun if I've got a lot of colours. So I've tried to keep the slides nice and colourful and lots of diagrams just to illustrate the major points. So it would be amazing if we had drugs that were 100% bioavailability, so there would be no first pass metabolism when the animal gets an oral drug. All of the drug that we give is therefore available for clinical effect. It doesn't interact with any other drugs. The formulation it's in doesn't cause any problems. For example, propofol has a lipid formulation and therefore is very bad to mix with any other drugs and can't be given IM, for example. You don't want to have any side effects on the cardiorespiratory system unless you're giving a cardiac drug. And you want to have reversible effects if that's desirable. It is anyway in anaesthesia. And you want to have the same and predictable pharmacokinetics in all species, so you know how the drug is going to react, how long the animal will be affected, etc. And it would be great if it was licensed as well. For the anaesthetic agents, it'd be great if we also had ones that were really fast onset and offset, so that the animal recovers very quickly and we have a nice smooth induction as well. And we don't want them to accumulate with repeat dosing because, again, the recovery will otherwise be quite long. So in German, I'm German, we have a thing called die eierlegende Wollmilchsau, which is basically a pig that's also woolly and lays eggs and produces milk. So basically you could feed the entire family forever. And that's pretty much, it exists to the same degree as these drugs properties that I've just mentioned. There's no drug that satisfies all of these things. So pharmacokinetics and pharmacodynamics, two fairly big words, and a lot of people get them confused. And really what it boils down to is that pharmacokinetics describes what the drug does in terms of entering, being moved around the body, and then leaving the body. So got this little diagram here. We'll give the dog a little oral tablet. It will then redistribute throughout the body. It will be taken up from the guts. It will then have a clinical effect by moving around in the bloodstream and getting to the effect site, and then it will be eliminated. Pharmacodynamics then is what the drug actually does to the body. So if we have a dog and it's painful, we give it some NSAID, for example. We fix the pain, but the dog starts vomiting. So basically the clinical effect that we tend to see is what the pharmacodynamics is. So pharmacokinetics overview, basically you administer the drug. You get the local concentration at the site where you've injected, for example, and that will then be affected by local blood flow and the concentration gradient. So the drugs will move along a concentration gradient into the plasma. That then therefore affects the plasma concentration. And the first place that these drugs tend to go is vessel-rich organs, so ones that are well perfused, brain, liver. Now for oral drugs, it's important that their first pass metabolism might significantly reduce bioavailability. Basically, a significant proportion of the drug might be metabolized and not actually available to contribute to the free drug, active drug plasma concentration. And the brain is very important because, especially for anesthetic agents, that is the effect site where we're going to have the drug actually acting and get the clinical effect. And then the concentration gradient will eventually draw the drugs back out of those vessel-rich areas, back into the central compartment, which is basically plasma, and then they will redistribute to vessel-poor organs or poorly perfused ones like fat, and that's where drugs can potentially contribute quite a lot to a hangover effect because the fat will slowly release the drug back into the plasma. And a point that's worth noting is that the majority of anesthetic agents, especially the induction agents, cease having their clinical effect because they redistribute away from the effect site rather than being eliminated from the body. So vessel poor organs will then also send the drug back into the plasma, and that will then generally get taken up by the liver. So the liver is the main first part in the pathway of elimination, and we've got the phase 1 and 2 reactions, which I'll cover a little bit more later on. And basically the idea is that the liver makes the drugs more soluble so that they can then be excreted in urine. But it's only able to clear a drug that's free, i.e. not bound to plasma proteins. And then it passes some of the drugs onto the kidneys, which then excrete it in urine. And both liver and kidney could produce active metabolites, and we've got to remember that they could prolong the effect of the drug action as well. So the big things that people always mention is absorption, distribution, and elimination, and we've covered them all in one slide. In terms of absorption, most anesthetic drugs are very small. They are lipophilic, which means that it's going to be easy for them to cross the majority of barriers in the body because most of them are made of lipid membranes. Therefore, they don't stay in the circulation very much because they're not very water soluble, and they tend to bind to plasma proteins as well, because that's preferable if you're not very water soluble. But again, only free drug is considered active in terms of being able to achieve a clinical effect. So another little diagram, we've got our various muscle, fat and skin layers, and then the vessels underneath. The drug is injected, and I've shown a very big lipid barrier there, but of course there's several lipid barriers on the way. That then gets taken up into the plasma, where some of it will be protein bound, and then any free drug is free to interact with receptors, which then have downstream responses and result in the clinical effect, and then we'd be on to pharmacodynamics. The take-home message is basically that drugs need to cross a lot of lipid barriers, and if they're not very fat soluble, then they're going to have a slower onset and more difficult time crossing. So absorption. Basically, I'm focusing on various parts of that big diagram I showed before. So now we're on to absorption specifically. So the local environment, let's say the muscle, for example, for an IM injection, will have a certain temperature. The animal's body temperature will affect it. There'll also be a certain pH, generally it's physiological, around 7.4, and that can affect how drugs react in terms of their conformation, for example, and therefore solubility in fat. That then determines the local drug concentration. So in terms of physicochemical properties, I'm talking about how fat soluble a molecule is, and therefore how able it is to cross a lipid barrier. If it's charged, then it tends to be water soluble, because water also has charges, whereas lipids don't tend to have the charge on the inside of the lipid membrane. And then if the molecule is very big, it becomes more difficult to just simply diffuse across a lipid barrier. It might need active transport, for example, so that will slow down or inhibit absorption. The local drug then will be able to diffuse down a concentration gradient into the plasma, where some of it will be free drug, as I've mentioned before, and then a certain amount will be taken away from availability to protein binding. But of course there's an equilibrium, so if you reduce the amount of free drug, then some of the bound drug will be released. Then we talk about the bioavailability again, so that will affect oral drugs, how much is actually absorbed. And then total body water and plasma protein content, of course, also affect the free drug concentration, because it affects the volumes in the plasma. And that is affected by disease state. So we can already see that this is becoming clinically relevant. And then the free drug is available for the clinical effect. In terms of onset of action, again, bioavailability is important because you might lose some of your drug. So I've included the lungs there because actually things like fentanyl are significantly affected by first pass circulation through the lungs. The majority of oral drugs that have first pass problems are related to hepatic metabolism. That then gives rise to the plasma concentration of the drug that's left and has actually been absorbed. And now we need to see how quickly the drug actually can act, because that depends on how quickly it can cross the lipid barrier, and that depends on the concentration gradient, its size, its charge, and how likely it is to be able to pass through lipids. And that then affects the effect site as well, so that would be where the drug actually has its action, and that's generally in places like the brain or the spinal cord. and of course there it has to cross more lipid barriers. And then another aspect to consider is how quickly did the drug actually get to the effect site, because that depends on cardiac output, circulation, perfusion, and therefore multiple factors which could be affected by anesthesia. For example, if you give an animal a drug during anesthesia. So just another little diagram to show the large ionized molecule struggling to get through and the unionized smaller one passing through the lipid membrane. And whether or not a drug is charged or uncharged depends on local pH and temperature, so it's an equilibrium reaction, and basically the pH can shift how much ionized and unionized drug is present, and that's relevant for drug formulations because people will intentionally manipulate the pH so that the drug is more water soluble in the vial, and then when it gets injected into the animal, there's a big pH change and it's actually quite lipophilic and able to cross barriers. So the next thing is a bit dense, and it does require a bit of patience to get through. So we'll talk about wash-in curves and wash-out curves, basically how the drugs enter a body compartment and what that concentration change looks like over time. And then what happens if you give intermittent boluses of drugs compared to a constant rate infusion with or without a loading dose, and then we'll look at elimination, half-time and half-lives. So with intermittent boluses, you can see that the peaks represent where we're giving the drug again, and the troughs are then between doses. So we've basically got a plasma concentration that we would like as the red line, and you can see that it takes us a while to get there first of all, and then once we get there we actually overshoot, and if that's a drug with a narrow therapeutic index then we could potentially be in trouble and near the toxic dose. And then between the doses it dips significantly, and the plasma concentration and effect site concentration might be so low that we actually don't have the clinical effects that we need. So sometimes we also have to actually widen the dose intervals, because if the drug accumulates we are much more likely to be in that toxic range. So intermittent bolusing, although it is commonly done, it does have significant disadvantages. So normally drugs, if you give them as a single bolus, have an exponential wash-in, and the same applies if you give them as an infusion. It does take a very long time to get to steady state, and so if you were to just put the animal, let's say, on a medetomidine infusion because it requires sedation and kennels, it will take a long time if you don't give a loading dose, because the drug A has to reach the animal through the extension sets usually, and then also the plasma concentration will rise very slowly. So if we add a loading dose, you can see that we get an initial peak, a bit like the boluses before, where we potentially overshoot our aim, but you can see that we reach the steady state sooner and the plasma concentration that we were actually going for, and there's a slightly quicker increase in plasma concentration even though there is an initial overshoot and dip. So if you're using an infusion, you should probably use a loading dose. But here we'll compare all the techniques, so it's a bit more obvious. So there's our infusion with the loading dose, there's our infusion without the loading dose, and then we have the intermittent boluses superimposed on top. So you can see that the intermittent boluses will significantly overshoot and potentially put us in a toxic range, and the loading dose will get us to a steady state concentration much quicker than if we just put on the infusion and wait. So therefore you should consider infusions if you're going to have an animal on a drug for a long time, and you're going to have to do a lot of repeat bolusing. And if you're going to use a CRI, it's recommended to use a loading dose. So we've made it to elimination. So we've got our drug in the plasma, and only free drug can be cleared by the liver, and that depends on the blood flow to the liver and the enzymatic extraction ratio. So that depends on the drug. So there are some drugs that really, the enzyme uptake from the blood is the limiting factor, and then there are drugs where blood flow to the liver is the limiting factor, and local anesthetics like lidocaine are a good example of that. So for example, if you anesthetize the animal and its cardiac output goes down significantly and blood flow to the liver does as well, then you might find that your lidocaine very quickly reaches toxic levels because it accumulates because the liver can't actually take it up because the blood flow is so rubbish. And then we've got the phase 1 and 2 reactions. So they're important because most anesthetic drugs require hepatic metabolism. And greyhounds, well, sighthounds in general, have polymorphisms in their cytochrome P450, specifically the one that metabolizes propofol. So there are many cytochrome P450 subtypes, and they all cross over in terms of what drugs they metabolize, but propofol in greyhounds and sighthounds in general gets metabolized incredibly slowly, and that would be a phase 1 reaction. And then cats, we know, aren't very good at metabolizing a lot of things, and that's because they've got very limited capacity for glucuronidation, which is a phase 2 reaction. So they have problems with paracetamol, morphine, and propofol, and the morphine in particular because it also has active metabolites. So hepatic disease is a significant thing to consider for anaesthetists because our drugs are so heavily metabolized in the liver. And we also need to know which ones have active metabolites, because morphine, diazepam, midazolam, and ketamine are sort of the big ones. And if you have an animal which has either hepatic or renal impairment, you might find that those really accumulate. Some drugs don't necessarily require hepatic metabolism because they're already water soluble, and an example for that would be the anticholinergics like atropine and glycopyrrolate. But there's certainly contribution from the drugs that have been made water soluble through hepatic metabolism that then go to the kidney and are excreted in urine, and how much is excreted depends on the filtration ratio or rate. And ketamine is one of those that's excreted in urine, and importantly in cats, ketamine is excreted as an active metabolite, so they make the active metabolite in the liver, and in dogs normally that gets converted into an inactive metabolite thereafter and then excreted, but in cats it remains active, so it could accumulate. But renal disease is not as significant usually in terms of accumulating drugs as hepatic disease. So now we're on to elimination half-life. So the wash-in curve is basically the opposite of the wash-out curve, which we can see here. A half-life refers to how long it takes for the drug plasma concentration to fall by 50% after giving a bolus. So we can see the first half-life is there, and then every subsequent half-life can take a different amount of time. And in general, to estimate how long it will take for a drug to be eliminated, the rule of thumb is that it takes 5 half-lives. Time constant is different. So the idea is that if your reaction had kept going at the same rate, so the little green line there shows what it would be if the reaction had kept going very speedily, i.e. the wash-in had kept going at a very quick rate. And for that to equate to an elimination of the drug is 3 time constants. So basically it lets you estimate how long it will take for a drug to be eliminated, and those are just 2 different methods of doing that. It's really important to consider though that elimination is not the same as terminating drug action. So the majority of anesthetic drugs have their action terminated by redistributing out of the vessel-rich effect sites, so brain, into fat, for example. And so the elimination that comes afterwards, when the fat releases the drug, is not the same as stopping the clinical effect. So it's in a way, this is slightly less relevant to anesthetic drugs, but it's still an important concept for all the other drugs that we've got. Context-sensitive half-time is another weird one. So it's confusing because we've just spoken about half-life, and now we're on to half-time. The main difference is that half-time is actually experimentally modeled, so it's not something that we can just draw a curve and then we can calculate how long it takes for the plasma concentration to halve, because this is one where an infusion has preceded basically the change in plasma concentration. So the half-life refers to one dose basically being given, and how long does that then take to get cleared out of the plasma. The context-sensitive half-time is we've given an infusion for quite a long time, and that's the context is the length of the infusion, and then once we've stopped it, how long does it take for the plasma concentration to fall by half. So it's more clinically relevant for the anesthetic drugs because it will tell us how long an animal will actually take to recover after an infusion. So here's the diagram of a few selected drugs that are often shown for context-sensitive half-time. So you can see that the infusion duration is indicated on the x-axis, and the context-sensitive half-time in minutes is indicated on the y-axis. So the longer the infusion is, so the further to the right on the x-axis, we can see that some drugs, like fentanyl and thiopental, have an increase in the context-sensitive half-time. So that means that it's going to take much longer for that plasma concentration to fall by half than it did when the infusion first started. And propofol, on the other hand, you can see even though the infusion's been going on for many hours, the propofol half-life in plasma or context-sensitive half-time is quite short by comparison. So initially the context-sensitive half-times are usually short for the majority of the drugs because they redistribute, and then if you give an infusion of drug for a very long time, the redistribution doesn't become as important anymore because everything is saturated, and then the elimination from the body becomes more relevant, and that is then when context-sensitive half-time actually starts to approximate half-life of elimination. So although they're two different concepts, they do overlap. So just to recap, half-time is the time that it takes for the plasma concentration to fall by half after you've given a dose of drug as a bolus, and the half-life is not a constant, so it changes in length. The time constant is how long it would take for the plasma concentration for the reaction to finish if it kept going at the initial rate. And the context-sensitive half-time then is how long it would take for the plasma concentration to fall by half after a certain duration of infusion. And for thiopental, there's another caveat, which is that hepatic enzymes become saturated and they basically can't handle any more thiopental, and that's why there's quite a steep curve sort of towards the end. Another important thing to consider is that these diagrams are based on human modeling, and of course humans are not the same as dogs and cats, and their pharmacokinetics will differ, and actually there's a recent paper out that shows that the context-sensitive half-time for fentanyl in dogs is much, much shorter than in people, so the curve might not be as scary looking on there, where your context-sensitive half-time just skyrockets after a certain amount of time. But the take-home message is, if your drug accumulates because you've given an infusion for a long time, your dog will be asleep for a very long time afterwards. And that's what the context-sensitive half-time tells you. So even though I said that infusions are a good way to go for constant plasma sort of concentrations and avoiding the peaks and troughs of repeat boluses, you do have the downside that the context-sensitive half-time comes into play. So why was all of that relevant? Why have we been talking about graphs? So pharmacokinetic modeling can help predict the onset of clinical effects. So when we're going through absorption and passing through lipid barriers and actually knowing about the drug's charge and molecular structure will help you predict how fast a drug can cross and therefore start its effect. You can model its duration of action and rate of elimination by measuring plasma concentration and seeing how it halves, and therefore seeing how fast it's cleared. And plasma concentration, although it's not the same as effect site concentration, can give us an indication of how much longer a clinical effect is likely to last. And then it can the pharmacokinetic modeling with plotting the repeat doses can give you an indication of the peaks and troughs associated with that, and therefore guide your dosing interval. But it's very important, as I just said, plasma concentration is not the same as effect site concentration. So for example, for the non-steroidal anti-inflammatory drugs, the effect site concentration can remain pretty high because they actually get concentrated in inflamed tissue when the plasma concentration has dropped significantly. So your plasma concentration of, for example, meloxicam is not going to be very high for 24 hours, but we dose it once a day because the effect site concentration remains high for a long period of time. And then we can use our pharmacokinetic data to develop target-controlled infusions, which is a big thing in people, where they use a lot of propofol or remifentanil infusions. The computer basically knows what the plasma concentration should be and then titrates the infusion either up or down to maintain that level. But the limitation is that target control infusions, for example, require modeling on actual experimental data rather than theoretical data, and that means that there's a lot of patient and individual differences and certainly species differences, and so that can't really be extrapolated from one to the other. So very quickly about pharmacodynamics, we'll talk about ion channels first, and basically these are the quickest messengers really that are available. So you've got your sodium channels, which are the standard example. The voltage gated ones are incredibly quick. The ligand gated ones, where acetylcholine binds, for example, are slightly slower. But the idea is that the sodium channel opens, sodium enters the cell, it depolarizes the membrane, and then cell signaling starts, and you get activation and excitation. And local anesthetics, which I'll cover in the Analgesia lecture, will affect the sodium channels and basically block them, and therefore block signaling. Then you have the channels that hyperpolarize membranes, so that would be the potassium channels where potassium flows out of the cell, or the chloride channels like the GABA-A receptor where chloride enters the cell. And the GABA-A receptor is really of huge interest in anesthesia because propofol, thiopental, etc. Act on GABA receptors. That then results in hyperpolarization, and that inhibits cell signaling, and therefore not very much happens after that. In terms of G protein coupled receptors, these are a bit slower than the ligand gated ion channels, and basically the drug comes, GDP gets exchanged for GTP, which activates the G protein part, which was the blue square, the yellow circle, and the red Pac-Man. That then the alpha unit flies off and then interacts with intracellular messengers, and you've got 3 different types of alpha unit, which basically determine what your signaling is going to be and therefore what your cell is going to do. So your GS, which stands for stimulating, increases cyclic AMP, and your inhibitory one, GI, reduces cyclic AMP. That then has opposite effects on ion channels, so cyclic AMP increases result in excitation and depolarization, whereas the opposite is true of GI. And then GQ increases phospholipase C, which essentially increases intracellular calcium, which also has an excitatory effect and causes depolarization. And the receptors that fall into this category are the opioid receptors, the muscarinic, cholinergic receptors, and adrenergic receptors. So a large proportion of drugs that we use in anesthesia will act on these G protein coupled receptors. So why do we care about that? All these receptors, which receptors activated obviously affects the clinical response, and do be aware that one drug will often activate a myriad of receptors, and it's particularly the endogenous type drugs like dopamine, for example, which have a range of actions on a range of receptors and is concentration dependent. So it's really quite a complex situation. And basically, our drugs will affect excitable cells. They'll either make them more excitable or less excitable. And then here we've got a diagram of the spinal cord pain pathway, a very schematic, but it's meant to show that it's quite complicated. So you've got many neurons coming from the dorsal horn in the spinal cord, and then you've got the red neuron there, which is an interneuron. So if you get tissue injury, you get signaling to the dorsal horn, and your pain pathway will be in full swing, and the purple neurons will take the pain signal to the brain. But if you give opioids, or if there's endogenous opioid release, you activate that inhibitory interneuron, and it will stop the signaling along the purple neuron and therefore the pain pathway. But it's important to know that there's lots of inhibitory on inhibitory, inhibitory on excitatory, etc. interactions of neurons, so it's very complex. And that in part explains why, for example, you get excitation when you give propofol too slowly or at a low dose. The sort of the inhibitory effect hasn't taken, and there's actually some excitatory pathways which are upregulated because they're less inhibited. And then once you get to your clinical dose, your animal is nice and anaesthetized because your overall inhibitory effect is taken over. So things are quite complicated, but I've tried to make them less complicated and just give a slightly more maybe clinically relevant overview of the pharmacology in this lecture. So thank you for listening. I know it's a bit dry and it's not necessarily the most exciting thing you've ever heard, but we will go on to sedatives and induction agents and maintenance inhalational agents in one lecture, and then we'll cover analgesics in another. So stay tuned for that, and I'll get on to recording that very soon. Thanks.